Good morning, everyone.
Good
Um, so
morning.
I, good morning. Um, I just want to welcome everyone to our. This is brought to you by the DEI committee and also the Health Equity Committee. So just want to welcome everyone to our talk on compassionate care. This is regarding supporting patients with developmental disabilities. The presenters for today are Gloria Jones. She is the Director of Health and Clinical Services at Connecticut Developmental Services, and also Denise Kennedy. She is the Chief Clinical Officer at Marrakech. Did I say that correctly?
Correct. Yes.
So I'm going to turn it over now to Gloria and Denise. And thank you for doing this. Thank you for doing this talk. And I anticipate we'll learn a lot and things that we could use in our practice. So thank you very much. And you have the floor.
Thank you. And like she said, I'm Gloria Jones, Director of Health and Clinical Services. So we'll go through the PowerPoint presentation, and Denise and I have split it up in a couple different ways through the slides. So I'll start off with a few of the slides and just want to say and acknowledge and thank you for the opportunity to be able to share more information about our individuals with IDD and how we could work together to get their needs met and how we can work together to actually share more information with your team as well. And so just to start, so what is IDD and DD? So intellectual and developmental disabilities, there's a lot of different things that are encompassed within that title. Developmental disabilities, some common things that we see: cerebral palsy, autism, Down syndrome, Angelman syndrome, which is a genetic disorder that affects the nerve systems, Cri-du-Chat, which is a chromosomal abnormality in infants that's discovered early on. Kabuki syndrome is a genetic disorder as well, affecting body systems and has autistic-like behaviors. Um, and so wanted to share that, as well as, there's a lot of comorbidities that occur when someone has intellectual and developmental disabilities. It could cause anxiety, severe reactions to loud noises, bright lights, sensory processing issues. Many of our individuals have GI disorders, may have epilepsy. Um, and so what we try to do is really to encompass what are their needs, what are they going through, what works best with them. And so anytime we have an individual with IDD or DD who's admitted to the hospital, we want to be able to share what works best with them in every situation, so that our individuals don't feel afraid or anxious, and your staff don't feel afraid and anxious taking care of our individuals as well. And so why is it important to know about some of the IDD and DD individuals and in healthcare? Because they do have very unique healthcare needs. And by that, I mean, they may have needs of what works best for a situational, what type of room they should be in. If they're in the emergency department, maybe in a corner or not in the middle where it's bright and it's very active, areas where it's not very noisy. And obviously in the emergency department, it's noisy all the time, but actually looking for many of our individuals are very sensitive to lots of loud noises, alarms, call bells, things like that going off. Effective communication is very important, understanding their needs. We often will send an individual initially with our individuals, a staff member, who can share some information on that initial visit about our individuals and if there's anything special that the hospital might need to be aware of that can really help the hospital support their needs as well. And so, and I think all of us, we want to provide compassionate patient and individualized care to every patient that goes into the hospital, especially those who may have intellectual disabilities. Next slide, please. Little about eligibility and sharing. Connecticut residents who have an intellectual disability, autism, or a medical diagnosis of Prader-Willi syndrome, which is a neurobehavioral genetic disorder, If they have an IQ of 69 or below, based on cognitive testing, if they have significant limitations in any adaptive functioning that began before the age of 18, and we evaluate them and determine whether they're eligible for continued services provided or even initial services and ongoing services provided by DDS and our counterparts that we work with. And so currently, we serve 8,634 individuals, and there are 17,199 individuals that are eligible for services. So as you can see, the numbers for those individuals in the state who have developmental or intellectual disabilities is very, very high. Next slide, please. And so the Department of Developmental Services, we partner with individuals, not only individuals, but families. And we find that our staff who work with our individuals, we have staff who've been working in family homes or with our individuals in group homes. Pardon? What? Did someone have a question? Oh, sorry. Some of our staff have been working with individuals for over 20, 25 years. And so we've connected in a way that we become families. And that's our goal, lifelong planning, to create opportunities where individuals can live a quality, healthy, and happy life in the community, not only in group homes, but in apartments and different living situations. And some of the different living situations that we have community living arrangements, they're CLAs. They used to be called group homes. We have continuous residential support. We have individual family support, individualized home support, and we have community companion homes where individuals apply to be caregivers and have people come into their private home and they oversee their care and take responsibility for them. And DDS Public supports about 5% of our population. And qualified providers. Um, qualified providers normally organizations like the DNCS, different agencies become qualified providers, which actually allows them to provide services through DDS and get funding through DDS to and they've met the established standards. It goes through our operations office. It also allows them to be able to assist with community-based waiver services. Our DDS qualified providers provide residential, nursing, behavioral, and day supports. And so private providers provide about 95% of our ID and DD population. And we'll just click on the link just to show you there's a list on our website of all of the qualified providers throughout the state. I don't know if you can open that up, Ilian, just for a minute. I know it's a little small, but as you can see, it's an alpha listing of all of the qualified providers. And so if you're ever looking for a qualified provider, if your hospital is involved in discharge planning, looking for someone who maybe does not have services or currently needs services, we have the qualified providers that your social workers can reach out to. Thank you, Elian. We'll go back to the presentation. And so we do have DDS home and community-based waivers. There is a waiver-based program that can be applied to, and certainly we have a team that looks at those applications to determine what kind of services individuals may qualify for. If in fact you have a family that comes into your hospital that may indeed need some additional support, the waiver application may be the way to go as well. And so looking at this slide, this is our last data report from 2019 in terms of where people live and where we provide services. And so people who live at home, family homes, their own home, um, is 11,449 individuals, which is amazing for us because initially, way back in the beginning of managing individuals with developmental and intellectual disabilities, most of them were in large facilities and housed in facilities. But as you can see, the trend is, and we're very pro having people have living out in the community. So they're living at home. We have some DDS operated and funded facilities as well that I mentioned in the prior slide. The companion homes, the CLAs, places that have 24-hour supports, DDS residential centers, respite centers. We have Southbury Training School, and those numbers are about 5,100 and 5,171. And then we have some other locations where some of our individuals are living. We do have some individuals in long-term care. We have some individuals in long-term care not funded by DDS, but funded. The family has made a decision that they wanted to place their loved ones in long-term care. We have individuals in residential schools, totaling 509. And then we have other state agencies as well that provide services for our individuals. DCF, we have some individuals under the age of 18, DEMIS, Department of Corrections as well, bringing us to that total of 17,199 of individuals who need services. And you can see by the graphs, if you look at the one on the right, the blue part really shows a really quick snapshot of the numbers of people that live in their own homes or own apartments with support with DDS. And so that's an amazing number of people. In the lighter blue, those who live in CLAs or what used to be called group homes. Next slide, please. And I will turn it over to Denise.
So So I work for Marrakesh. For those of you who don't know about Marrakesh, we are a private nonprofit organization that provides services to people with and without disabilities. We are statewide. We have group homes and day programs and continuous residential support day programs. We provide services for people living in their own apartments. So we have a variety of different services. And I've been working with Marrakesh for 29 years now. So I have a lot of experience working with people with IDD. So I will talk about some key characteristics of people with IDD. Individuals may have cognitive impairments. Eliana, if you could go to the next slide. Difficulty with problem solving, learning, and reasoning. So they may have difficulty following conversations during appointments. They may forget things more easily, or they might make poor decisions. So if you're trying to talk to someone about the importance of smoking, right? If you want them to, not smoke or smoke less, they may not have the ability to remember that once they leave the office, or they may continue to smoke and make those sort of decisions because of their cognitive limitations. They may have behavioral challenges, which may include difficulty with communicating, repetitive behaviors, or social challenges as well. They may have physical limitations, may have motor impairments or medical conditions that require special attention. Are they able to get on and off the exam table? Are you able to fully assess them if they're in their wheelchair? So you have to be cognizant of things like that as well. And our individuals have varied abilities. The severity of IDD can vary widely from mild to profound and should be considered in the care planning. That's why it's important to provide person-centered care and treat each individual as a unique person. So some differences between people with IDD and neurotypical or typical or average people in the general population. Cognitive processing. People with IDD may process information more slowly or have trouble with abstract thinking. So you want to be mindful of this when you're communicating information to them. Neurotypical individuals generally have faster cognitive processing and better abstract reasoning. Communication, individuals with IDD may have delayed or limited verbal communication skills, or they may be nonverbal and need augmented communication methods such as picture boards or sign language may be essential. And these are things that may not be needed by someone who's neurotypical. Social interactions, social cues and norms might be misunderstood by individuals with IDD. An innocent hug or a term of endearment may be misunderstood as something more than a provider-patient relationship. So you want to be cognizant of that. People with IDD may have limited social understanding or experiences. So if they're in the office, they may not understand boundaries, right? So they may want to come up to you and hug you, or may touch everything in the office. They may not understand those social cues. Sensory sensitivity. Many individuals with IDD are sensitive to sensory stimuli, such as lights, sounds, or textures, which may not affect neurotypical individuals. We had an individual that we received from an institution, and she spent most of her time in a white room. So when we brought her to doctor's appointments, we had to ask the physician to remove his white coat. And when she was admitted into the hospital, we had to bring colored sheets from home and colored pajamas because it was trauma for her. So we had to be cognizant of that. So making sure that we are aware of their sensitivity to sensory issues as well. So some common challenges working with people with disabilities: communication barriers, difficulty expressing needs or understanding medical information. So you want to relay information in layman's terms or in ways that can be easily understood. They rely on caregivers to communicate, which adds to the complexity. And most often, if they're being at the appointment with the staff, most staff have like a high school education and they're not medical professionals. So you want to make sure that you're providing information in a way that could be easily understood and then brought back to the program and relayed to the team. Medical history and conditions. People with IDD often have co-occurring medical conditions such as epilepsy, GI issues, or respiratory problems. Comprehensive medical histories may be lacking or difficult to obtain, especially if they have little or no family involvement. It may be difficult to get that past medical history. Behavioral issues, anxiety, frustration, or stress may manifest in challenging behaviors. It may look like aggression or withdrawal, but that may be a way that the individual communicates, especially for our individuals who are nonverbal. And again, sensory overload. You want to be mindful of the hospital environment, like Gloria said earlier. Bright lights, loud sounds, strong smells can be triggering for our individuals. So the healthcare goals, we all want to improve the standards of healthcare for individuals with IDD to promote the same level of preventative care and medical treatment options that other members of the community are afforded. And those goals can be accomplished by providing person-centered planning, a multidisciplinary provider approach, community access to healthcare, minimum preventative guidelines, which Gloria will go over in the next slide, and lifelong planning with dignity and respect.
Thank you, Denise. And so one of the things that we use as a guide is there is a preventative guideline task force that develops minimum preventative guidelines. And so I'm not sure if you can make that a little bigger, Ilian. And so the guidelines are broken down by age of our individuals, and what we kind of hold to these guidelines for basic care and oversight. For an example, hearing and vision. Um, if someone has had no issues with hearing and vision under screenings, the provider may say there's no need to do an actual vision exam for this individual. There's no change based on my exam, and there's some documentation to be filled out for that. But if we go back to if we go down to dysphagia and swallowing risk screening, if someone has the diagnosis of dysphagia, certainly there's always ongoing evaluations every time there's a doctor's appointment, every time there's a visit, anytime they go to GI, and actually looking at the symptoms and the risk factors. So this is very important because we use this as a foundation for minimum screening guidelines for all of our individuals. And so if you ever have a question with any of our individuals who've come in, we can certainly access this information for you to let you know when they've had different tests and things done. Some of the other type of things, On this next page for immunizations, pretty standard in terms of what needs to be done. Some things where if our individuals are not high risk, the providers can determine that and fill out a form for an exception or an exemption from that. In terms of x-rays, many of our individuals are very prone to spinal instability. And so it depends on the exam and what the x-rays have showed in the past, whether providers would determine how often they would have to have another x-ray to evaluate where they're at with that. Thank you. Next slide. We also have the dental recommendations as well. And so we do have recommendations based on age, again, following the same screening guidelines. And again, depending on the individual and what their needs are and what's going on, it's clinical discretion for how often someone needs to have x-rays. All of our individuals have annual oral exams and annual cleanings, as well as recommendations for brushing, flossing, or anything else that is recommended by the dentist for good oral hygiene. For prophylaxis, maybe someone has a lot of plaque in their teeth, in their gum lines, so many times they would come back to our dental clinics at least twice a year, depending on if it's indicated, depending on whether they're able to really brush and floss and get everything done that they need to get done at home. Partial exams can also be another thing. All of our dentists do recommend that we brush the teeth of our individuals or assist them or guide them or remind them to brush their teeth twice a day. Next slide.
Before you move on to that, Gloria, I just want to add that as a provider, oftentimes our staff will bring a physician progress or consult sheet with our individuals to the appointment. And this is how we demonstrate to DDS that we are in compliance with all of these preventative guideline appointments, is by having the physician or the physician's office complete that form for us. So it's important that when we bring the individual to the doctor, that form is filled out and we have it on hand. So when we do go through licensing or a QSR audit, when the surveyor is looking for documentation to demonstrate compliance, that we are making sure that our individuals are maintaining their preventative health care, that form is on hand for us.
Thank you. Thanks for adding that, Denise. That's very helpful. Absolutely.
And I also wanted to highlight Isabella Pulvermacher, the dental coordinator. She's statewide. Her email address is there, and she can be contacted by the dental offices if you guys ever want education or you have difficulty with meeting an individual's needs. She's really great at coordinating the care for dental.
Thank you, Ilian. Challenges assessing healthcare. And so some of the challenges that we're seeing statewide for our individuals is really finding providers who can take the time to evaluate our individuals, to work with them. Certainly many of our individuals would not fit into a 15-minute follow-up appointment. They might need extra time. They might need extra time in the waiting room. They might need some extra time getting acclimated into an exam room. If they're in a wheelchair, they need the extra time to maneuver in and out of the wheelchair. We have a lot of psychiatric healthcare providers that do provide services for our individuals and consultant services, contractual services. We have lots of primary care providers that have been following our individuals for years. And anytime we can give education or information that would help other providers to provide care for our individuals, we are 100% all in for whatever we need to do. Best practice guidelines. I think every provider follows best practice guidelines, and that's all that we would ask as well. And certainly the time that it takes many times, like I said, to work with our individuals is a bit longer. Number one, because sometimes there's some intellectual disability, and so it takes time. You have to be a little more patient. And if there's developmental disabilities, maybe they're not as mobile in and out of the office or in and out of the chair or from the waiting room, or maybe they're just anxious and there might be behavioral issues related to that. And so the important thing is really recognizing that there may be some differences with our individuals that may require some more patience, some more time, and certainly using our staff as support for appointments as well. But again, recognizing, like Denise said, our staff many times have high school diplomas, and they're not medical people, but certainly personal information they could certainly share in terms of how they work well with the individual and what works best with them. We do have Health Standard 9-2, which is available on our website, which talks about deferred, limited, or declined health care. We get guardian consent for treatment. That's in our Health Standard 19-1 for both medical, dental, and also any kind of emergency surgery. Thank you. For end of life care, and many of you may have been involved with this. For any of our individuals, there is a process that has to be that we go through based on our Connecticut General Statute 17A-238G. And so we evaluate whether we could proceed with an advance directive based on many different things. And what we're looking for, if a provider or if the hospital is looking for to change a code status on someone, we're looking to see, is it based on chronic irreversible illness or not? Not necessarily an intellectual disability. Yes, that's a permanent chronic disease. But when you're in the hospital, we're looking to see if it's a chronic irreversible medical or clinical decision that's being made. And we need to have an agreement with two providers that agree that something is chronic and irreversible. A good example of that is maybe someone has dysphagia. They may have had multiple admissions over the past month because they've been aspirating, or they're drinking too fast, or they're not drinking, they're not taking their time when they're eating. And so because of the dysphagia, they may aspirate, or they may have some choking episodes and may have frequent hospital visits. And so we recently had someone who had been in and out of the hospital, I want to say 6 or 7 times related to that. And the next step was a possibility of maybe a G tube for tube feedings, but it wasn't an option for that particular individual. And so the hospital team came together, social worker, case manager, the guardian, the individual. Many of our individuals have guardians. Many of our individuals are responsible for themselves and may have living wills in place, which we honor every living will that an individual has established. And so if someone has established a living will, and there's been a change in their cognition status, we would still honor that living will that they made when they were able to make that. The review process normally would go through the regional health service director with that information. And then it goes through the commissioner of DDS, and a decision is made to approve it based on the medical information that we receive in those letters. We do not review DNR orders when there's already advanced directives in place or living wills in place. If someone has advanced directives, copies should be in the chart. If it's not available, you could call the family, the guardian, the case manager to get a copy of those advanced directives or living wills if they should have copies, and certainly so that you would have those in place. We also have mortality reviews after someone has expired. And it's a very involved mortality review process. We're looking at making sure that, was it a normal situation? What did the death report say? What happened leading to the hospitalization? What happened prior to the person going to the hospital? What happened if there were multiple admissions to the hospital? So we look at all the situations related to the hospital admission. If it was a death that occurred while in the hospital, we're reevaluating everything that led up to that as part of our mortality review process. Thank you. Next slide.
Okay, and I will talk about, okay, what can you guys do as providers to provide effective care? And I'm also a member of the DDS Mortality Review Board, so I'm part of that process. So what can you guys do as healthcare providers? You can provide clear and simple communication, use simple, direct language, Be patient and give individuals time to respond. Like Gloria said, a 15-minute follow-up appointment may not be enough for our individuals. And if needed, use visual aids or communication boards. You want to make sure that the person is receiving the information the best to their ability. Create a calm and safe environment. Minimize sensory overload. Sometimes you may have to dim the lights in the room. Offer a quieter area if possible for the individual if it's too much stimuli for that person. And involve the caregiver. Caregivers often know the patient's preferences, triggers, and communication methods. Ensure they are involved in the care process. And sometimes it's a parent or guardian, family member, and sometimes it's the staff that works with them for many years who knows them best. Respect and acknowledge individual differences. This is where person-centered care comes in. Recognize that individuals with IDD may have unique ways of understanding and responding to situations. Treat each individual with respect, avoiding assumptions based on their disability. Use positive reinforcement, acknowledge positive behaviors and responses. Great job, Jenny. You were patient. Thank you for waiting. I was 5 minutes late. Or reinforce cooperation, even small steps. Thank you so much for allowing me to look in your ear with praise or other positive feedback. That goes a long way with our individuals. And prepare the individual in advance. You want to explain the procedure. Don't just automatically start touching the individual and start examining them, right? That may be a triggering for them. So you want to explain what you're going to do. Use visual supports or simplified language, and give them time to process and ask questions if necessary. Approaches to medical procedures, the pre-procedure, you're going to provide clear and visual information about what will happen, why it's needed, and how it will be done. And again, you want to use terms and language that's easy for them to understand. Allow the individual to have a comfort object or person with them during the procedure if possible. I know when our individuals or most individuals go into the hospital, it's important to have like their favorite staff person with them or a picture of a family member, or if they have a favorite object, it's important to have with them. During the procedure, maintain a calm demeanor and use reassuring language. It's okay. Some individuals may have a lot of anxiety or stress about getting a procedure. It's okay. You're safe. It's going to be okay. We're just going to do this procedure. You'll be fine. You just want to reassure the individual. Use physical touch or positioning that is comfortable for the person. Not everyone likes to be touched. That's why it's important to know your individual. And if it is okay and they are okay with physical touch, you want to just maybe put your hand gently on their shoulder just to give them that reassuring touch. And after the procedure, be mindful of how the individual might process the experience afterwards and offer emotional support. And follow up to ensure comfort and reduce any distress from the experience. Check in with the individual. Are you okay? Here's the follow-up. And make sure that you're also providing information to the staff, because they are most likely going to have to relay that information back to the team when they go back to the program or to their family when they go back home, that they know what to do after the procedure. Some sensory considerations, again, adjust the environment, dimming the lights, reducing the noise if possible, providing sensory-friendly material such as soft fabrics, fidget items, anything that's going to help that individual feel comfortable and supported through that appointment. And you want to monitor for overstimulation, right? You want to pay attention to signs of distress. The person may start tapping their leg or getting jittery or start pacing or rocking back and forth. You want to pay attention to that. And if you start to notice that, you want to start using calm language and softer tone and start reassuring the individual that they are okay. And provide frequent breaks if necessary. So handling behavioral challenges and understand why behaviors occur. Fear, right? Fear of the unknown. They don't know what's going to happen. Pain or the hospital environment can trigger aggression or withdrawal. We don't know past experiences. They may have had a traumatic experience. So you want to look for signs like avoiding eye contact, verbal protest, or physical withdrawal to address fear appropriately. I see that you seem a little anxious. What's going on? What's bothering you? Try to offer that reassurance. Pain or discomfort. Many individuals with IDD are nonverbal and may express pain through behaviors like aggression or irritability. So you want to watch for signs such as holding the painful area, wincing, or changes in posture. Difficulty communicating, frustration from an inability to express needs or feelings can lead to challenging behaviors. Aggression or resistance may occur due to communication difficulties. They can't express that they're in pain. They can't tell you what's going on, so they may become frustrated and become behavioral. So how can you handle that if they are behavioral during an appointment? Redirection. When a person displays challenging behaviors, try to redirect their attention to a different activity or task. For example, if the person is becoming agitated, you could gently shift their focus by asking them to hold their favorite object or look at a calming picture in the room. Redirection can also involve engaging them in simple calming activities like squeezing a stress ball, using a fidget toy, or focusing on a visual aid, or just asking them to sit and just take a couple of deep breaths. Can also be a form of redirection. Calming techniques, deep breathing, gentle touch, and distraction can also help when a person is exhibiting challenging behaviors. Gloria, do you mind covering this slide really quick, just while I take a swig of my water?
Sure.
Okay.
And just wanted to add to the last slide as well. Many of our individuals have tablets, and so that also can be a calming device that they can use if they're waiting. They may have different games they play on it or something they're reading on it. That would be very useful. And so why consistency is important? Because when we're consistent and we're all saying the same thing, it helps build trust. It helps avoid confusion. Many of our individuals, routine and consistency is very, very important. If our individuals go to a day program on Wednesdays and Fridays, the night before, they're reminded that they're going the next day. When they wake up in the morning, they're reminded that today's the day you go to your day program. And so that consistency also helps provide a calming approach to reminding them of where they're going and what they're doing. And so as staff share those things with them, even in the hospital, the consistency. I have to take some blood from you because I need to get the blood reports for your doctor. Okay, we have the blood. The blood results are back. We're going to call your doctor and let your doctor know what they are. That consistency and that information sharing, it helps reduce the anxiety. It helps prevent anxiety that may cause challenging behaviors. One example is if one nurse is firm and one is lenient, our individual might not know how they're supposed to react to one or the other, and get very, very anxious about that. How do we build trust? And I think consistency, even in our own lives, but in the lives of our individuals, that consistency, the routine, really helps to calm them. And it's very helpful in the emergency room, in hospital stays, in clinic stays, day programs, no matter where they go. That calm consistency, reassurance, so that they know what's going to happen next. And I think that's very important. Thank you. Next slide.
Thank
Other
you.
ways to, did you want to do this, Denise?
Yeah, I could take back over.
Okay, thank you.
Okay, clear communication amongst staff. All staff members should be aware and follow the same strategies when responding to challenging behaviors. You can't have one health provider behaving one way and then, like Gloria said, another one behaving another way, because it could be really confusing to the individual. So you want to have clear communication amongst the providers. Document and share insight. You want to keep a record of behaviors and any strategies that may have been successful, because you may not be there the next time the individual is there for their appointment. So you want to make sure that your colleagues know how to best work with the individual. And follow routine. People with IDD benefit from having consistent routines. And so try to keep the care routines, meals, and activities as consistent as possible. And this familiarity can reduce anxiety and improve cooperation. And if changes are necessary, you're going to introduce them gradually. You're going to communicate those changes, right? You're not going to just change something on them because that can be triggering. You're going to explain, I know yesterday, you were working with, your aide Lisa, who was your favorite aide, but Lisa is off today, and now you're going to be working with Tony. So you just want to make sure you're communicating changes. So why is de-escalation so important? So preventing escalation, you want to prevent the situation from becoming worse, right? Which involve the person becoming more agitated or aggressive. So the sooner you can notice that a situation is starting to brew and start to de-escalate it, that's the key to bringing the situation back to a normal, calm environment. And minimize trauma. De-escalation can help minimize emotional and physical trauma for both the individual with IDD and the healthcare providers involved. Avoiding restraints and other interventions that may increase stress is essential for providing compassionate care. Remain calm and not non-threatening. It may be very overwhelming or scary for a provider if an individual goes into a behavior during an appointment or a hospital admission. So you want to be mindful of your own demeanor, your own tone, and how that may play a role in de-escalating a situation. Our individuals are very sensitive to body language and tone of voice. So it's crucial for you to stay calm and composed and non-threatening. And respectful. Speak in soft, gentle voices and avoid raising your voice, even if you become frustrated with the situation, right? We're all human. So even if you do become frustrated, you want to make sure that you're monitoring your mannerisms and behaviors not to further trigger and escalate the situation. And again, reassurance is so important for individuals with IDD, letting them know that it's okay, that it's safe, they're safe, that you're there to help them and take care of them is extremely important. Again, give clear, simple instructions. Our individuals may have difficulty understanding complex instructions when they are agitated. So you want to give short, simple instructions, one step at a time. Use clear, direct language, such as please sit down. Let's take some deep breaths together. Avoid overwhelming them with too much information at once. And speak slowly and clearly, pausing to check for understanding. And provide space if needed. Sometimes the person may need space to calm down. It's okay if the person says, I need a minute, if they're able to, or the staff that knows the individuals during the appointment may say, this is a little bit too much for them. Can you leave the room for 5 minutes? They're not being disrespectful. They know the individual and they know that at this moment they need a break. So if they become agitated, offer a quieter area and allow them to take space. And then engage the individual with comfort tools. If the individual has specific items such as a favorite blanket, soft toys, or headphones, offer these to help them feel more secure. Some individuals may respond positively to sensory calming methods such as soft music, a weighted blanket, or a favorite scent to reduce anxiety. And again, the individuals who are with them on the appointment will know this information and should provide this information to you as a healthcare provider to make sure that the appointment or the hospital admission is smooth. But Gloria, do you want to go over the key takeaways?
Sure. Thank you. So the key takeaways that we wanted to share with you today is that individuals with IDD and DD have unique healthcare needs, and so every approach is specific and tailored to meet their needs and their behaviors and their clinical decisions that need to be made. That patience, clear communication, and sensory accommodations are essential to keep them calm and relaxed whenever possible. Involving caregivers, use positive reinforcement and respect the individuality of each person, person-centered care. Understand that behavioral challenges are often a form of communication, and just being aware that sometimes you have to adapt to strategies. Like Denise said, maybe the staff member might say, if you could step out for a few minutes, I know how to calm this individual down and just come back in 5 minutes. But just, again, taking the extra time. Any questions for us?
We wanted to also, before we get into questions, we wanted to also, guys, let you know about the CTDDNA, where we are members of. It is the Connecticut CTDDNA is a professional organization committed to advocacy, education, and support that strengthens intellectual and developmental disability IDD nurses. Our goal is to empower each member with the resources and tools necessary to practice in this expertise successfully. So if you are interested in learning more about CTDDNA or becoming a member of CTDDNA, there is the QR code that will bring you directly to our website. We offer a lot of educational opportunities, continuing credit, education credits, networking opportunities, the ability to become a certified developmental disability nurse, and a lot more offerings. So just check us out. If you scan the QR code, you'll be directed to the website where you can get more information. And now we can open up for questions. Sorry, Gloria, I just want to plug
Oh,
our
no problem. Thank you.
CTDDA really quick. Okay. So are there any questions?
Hi, this is not a question, but I just tried to use the QR code and it says that it has been deactivated.
Okay, I will get you, Misha, a updated code for you to send out to everyone.
Perfect, thank you.
Any questions or maybe situations that you've encountered with our individuals that maybe we can support you and answer any questions you may have, even for something that may have happened in the past? Was this helpful for you?
Yes.
I would say very helpful.
Good. One other thing I did want to bring up, and Michelle, will come back to you in a second, is the question always comes up when our individuals are admitted into the hospital that our staff stay with them while they're admitted into the hospital. And I just wanted to let you guys know that we can't staff the hospital. We will definitely send staff to be with the individual, to visit, to check in, but we're not permitted to have a staff like 7 to 3 and then 3 to 11 and then 11 to 7. Once they become admitted into the hospital, they become the care and custody of the hospital. And then so we cannot provide staff 24/7 around the clock. There may be extenuating circumstances where we will make exceptions for that, but that is not the norm for us to provide staff at the hospital when the individual is admitted. We will most certainly, agency should send this individual with staff to the hospital to be with them up and through the admitting process. But once the person is admitted into the hospital, the individual becomes into the care and custody of the hospital. And we are the support for the hospital.
And I think that being said, if there are questions that come up regarding the care or behaviors or concerns specific to individuals, certainly reach out to the case manager, reach out to the group home, the guardian, the family, who can support as well as answer questions and give some guidance and direction as well.
Yeah, the nurse should be, the program nurse should be in contact with the hospital nurse during that admission, throughout the whole admission process. So there should be that collaborative effort going on. Michelle, I saw that you started to unmute.
Hi, I was just wanted a little clarity about toward the beginning of the presentation. There were two different numbers of the amount of people identified with IDD as opposed to the amount in your care. I believe that was how it was stated, if I can recall. And there was like, I think the number was like 17,000 something, and then in your care was like 8,000 something. So,
Yes.
so can I just have a little clarity as far as how are they identified? And then how do you guys determine when you provide services and care. So I'm just wondering, the discrepancy of the numbers is really all.
And so if we can go back to that slide, and so there were 17,000 of those individuals who weren't directly provided care by DDS, but that they were in home, they were with family. Sometimes their in-home supports where family hire people to come in to support them at home. If you want to look at that line number
It's slide 4,
3,
Elia, I believe. Oh,
at home. Oh, that was it. I wanted to
okay.
Yes, so on this slide, I talked about that we provided services for about 5,000 individuals, but that there were another almost 12,000 that didn't really receive care directly by DDS. And if you look at this number here, 11,449 on that at-home subtotal,
Mhm.
can you see that? And
Yes, I
so a
do.
lot
Thank
of
you.
those individuals live with their family, they live with guardians, they live with relatives, they might live in their own apartment, their own home. And so they don't really need supportive DDS services. They're doing pretty well on their own. And sometimes they will do self-hires. Family may hire people to come in maybe a couple hours a day to do different things with individuals. They may go to day programs. But those are the individuals that are living in their homes or their own apartments, but still have the diagnosis of ID or DD.
Okay,
Does
thank
that
you for
help
that.
answer your question
Yeah,
with the
yeah,
number?
yeah.
Yeah.
Thank you for that clarification. And then how do they go about reaching out to you if they were to require services?
And so many of them do have case managers, some do not. They would be able to call central office. They would be able to go online to inquire about additional services they may need. Maybe it's something the guardian will do or the family member may do. And then there's an application process to determine what needs we would be able to provide.
Thank you.
You're welcome.
I just provided the link for the eligibility unit in the chat box.
That was a great
Jeremy, I see that
question.
you unmuted.
Yeah, I just have a question. First of all, it was an excellent presentation, and thank you. I was just wondering, in terms of hospitals in general, not just our hospital, but hospitals in general, what are the typical pain points that you see with dealing with hospitals or healthcare providers that we could do better at?
Well, as a provider, I know I met with hospital faculty not too long ago, is when it comes to the discharge planning, the hospital staff may feel like the individual is at baseline from a hospital perspective, like the labs are normal, the person may be at baseline presenting for the hospital, but as a provider and as a staff and people who know the individual best, we know that the individual is not at their baseline and not ready for discharge. So it's a little bit of the battle of, accepting that person back at that moment of discharge versus saying, no, the person is not ready. We know this individual. And 9 times out of 10, it happens when the person is discharged, they end up right back within the next day or two because we knew they were not ready to be discharged. That is one pain point. And then the other pain point is just the providers not knowing how to deal with our population, right? Not having the patience or the understanding, no judgment if they're not used to dealing with someone who's becoming agitated or behavioral during an appointment, or if they're used to dealing with neurotypical people who can get through an appointment in 15 minutes. And now we have to slow that process down when you have other patients waiting for their appointment. And we're saying, well, we need more time with you or more time with the doctor for our individual, then that can become a little bit challenging.
Yeah, if I could add to that too, in terms of the first scenario with discharge planning, and really whenever anyone is admitted to the hospital, discharge planning begins on day one. And I think because we really want to be collaborative, we want to work together, it's really making sure that we're at the table when plans are being made and evaluations are being made, especially in relation to baselines. If someone was independent, walking around, never needed assistance, and then at the hospital for some reason were not able to walk, were not able to stand or transfer independently, we have to really evaluate, is the place that they were living, is it appropriate for them to go back to? And so many times we may have to look at additional places for individuals based on their functional mobility as well. And so really it's important to bring us to the table and keep us in that loop with all the discharge planning meetings so that we really can do the best thing for our individuals as well as for the hospital discharge planners.
And one last thing is the DNR process, right? Is the changing someone's code status, not realizing that there is a process for our individuals that we have to adhere to, and code statuses are changed without that process happening.
Yeah. And I also wanted to add to, related to discharge, a lot of times people may feel that the group homes are kind of like medical staff are there. And if the person has a new oxygen, they can just go home with that. There takes a lot of coordination when it comes to things like that. So anytime someone's coming with services from DDS, we should really figure out where they're living, what their needs are currently, and what their needs are going to be, and how we can work together to make sure that all their needs are met.
So I'd like to just chime in on that process. My name is Priscilla. I'm the Regional Director for Case Management for ECHN and Waterbury Health. And I agree 100% regarding the collaboration. And with the new process I have with my team at Waterbury, the structure for social workers involved in our complex cases like patients who are managed by DSS or DDS, excuse me, we make it our prerogative to ensure that we have the collaborative meetings to talk about patient's baseline and what the group homes can and cannot do, what the patient needs upon discharge. My team is well versed and well educated regarding the complexity of this population. And our goal is to ensure safe discharge. Also, as stated by Gloria, discharge planning is of day one. So we hope to have those conversations early on. We don't like to wait to the last minute to facilitate a smooth transfer for for our patients. So definitely in alignment with that thinking. My team is on the same page and we're still working on that. With, we do encounter some difficulties. Of course, there's some challenging discharges, but our ultimate goal is to have our patients return to the group home if the group home can meet their needs. And we understand in those circumstances, if the needs cannot be met, then for sure we need to discuss an alternative plan for them.
Thank you for
Thank
that,
you.
Priscilla. Yeah,
Kudos
because a
to
lot
your
of
team.
providers don't have 24/7 nurses. And I think that is also like a misunderstanding that group homes have 24-hour nursing around the clock, and most providers don't have
Yeah, they don't.
have that.
Hmm. Any other questions?
Well, Gloria and I are super excited that we had the opportunity to get in front of you guys today and do this presentation. We want to do more of these presentations and work collaboratively with healthcare providers because we all have the same. Oh, you're welcome, Nita. The same goal is to make sure that our individuals have effective healthcare, and it's a collaborative effort between the healthcare provider, the individual, the agencies, the guardians, and everyone involved.
Mm-hmm. If there are situations that come up, or if there's more information that you think you may need down the road that we can support you in, certainly reach out to us and we'll be more than happy to do that.
Well, thank you guys
Thank
so
you
much.
very much.
Okay,
doing this
Anisha,
talk
I will
with
get
us.
you an updated QSR
Okay.
code. I made a QR code.
Yes, definitely. Thank you guys so much for doing this talk. It's definitely needed.
Thank you.
Thank you.
Thank you for the invite.
Oh, you're most welcome.
Okay. Bye-bye.
All right,
Take
bye.
care.